This episode of the Operatory podcast is brought to you by Opera DDS, the easy solution for communication in your dental practice, between dental practices, and with your specialists. Paperless forms, secure email, full recall, and intra-office communication with chat and teledentistry, all available at operadds.com. Welcome to the Operatory, the podcast about burying the dinosaurs in dentistry, moving past outdated technology and procedures to find a better way. With me, as always, today's special day, your birthday, my man. How are you doing, Dave?
Good. How are you, Brian?
Good, good. Thanks for coming to the Operatory on your birthday. You wouldn't rather do anything else on your birthday, would you?
No, Brian. No, I would not. Oh, wait. No, I would. I'd rather go to Mexico.
Oh, yeah. Well, that's tomorrow, right?
That's tomorrow.
Yeah, it's like, what, 5 degrees below zero here in Minnesota?
It is.
So, yeah, it's a good thing.
Sunny and frigid.
And with us today in the studio, we have an amazingly special guest. We're going to be doing a series with Dr. Brad Eli. So thanks for being here.
Thank you for having me.
Well, could you, for our audience, give an overview of sort of your training and how you got to where you are in dentistry and facial pain and the specialty focused area that you're in today?
Sure. So I got interested in oral facial pain or temporomandibular joint disorders after graduating from dental school, and was smart enough and or dumb enough to go back to a postgraduate training program. And so I officially am a specialty trained postgraduate 2-year blah-de-dee-blah.
Blah-de-blah-de-blah. That's nice. Well, and as we were setting up this podcast, you were kind of describing what your blah-de-blah is. And it's basically treating the untreatable patient, right? Things that are not untreatable, but things that dentists go, I treated this patient, I've done everything, what the hell's going on?
Right. So I distinctly remember...
Like Dave, I would say.
Yeah.
So I'm already getting fried on this one.
Yeah, well, it's your birthday. So, when I would go to potential referral sources in my first year, I would go to the front desk person and to the assistant, and I would say, who don't you ever want to see again? That's who I take care of.
Yeah. Yeah, and you were describing to me sort of how in dentistry, we're taught a certain level of skills, and and most people fall in the basket of conditions that we're talking about. But you deal with the others that when we look at them, we go, do you have pain? It must not be, it's not anything that I see that's going on. It's something that's probably 6 inches north of where your teeth are. Does that kind of...
a lot of people, unfortunately, were identified as being crazy, making it up, because there wasn't a obvious dental explanation for the problem. So, x-rays would be taken, patients would be put on antibiotics, endodontic treatment would be done, and the pain would still be present. And so that became a population that really started to confound everyone. Mm-hmm. And so some very forward-thinking people at UCLA put together this program, and I was lucky enough to be in the first class. And so when I was delivered from it in 1992, I spent my first 10 years of practice in a university-based pain center with a bunch of anesthesiologists taking care of people who had 10 root canals chasing a facial pain complaint.
I would guess the listeners that are dentists probably have those patients where you see and they have like root canal on almost every tooth, yet they're still complaining of pain.
Yes.
That's my nightmare and your patient.
That is correct.
Okay. Yeah.
And how those develop when you take these patients' histories, unfortunately, the way it develops is that a patient goes to their dentist, with what looks to be a toothache. But it's really not a toothache. And so maybe the dentist sends them to an endodontist, and the endodontist does root canal therapy on them. And many of these types of disorders will actually go away for a week to a month from a procedure. So then what will happen is when the symptom returns, they'll return to the person who did that root canal, and that person will say, well, we must have done the wrong tooth. So then that's what commits the next tooth to the disaster. And so as the person moves along, human beings do what human beings do, and that is they lose confidence in the person treating them. So they say, well, this endodontist must not know what they're doing. I'm going to go to the next endodontist, thinking that the new provider will pick up where the old provider left off. But as you know, we were all trained the same. So they all start from square one again and start the same process. And so it is very common for us to see that person who has seen multiple providers. When I was in the pain center, the average patient had seen 7 providers prior to seeing me.
Wow. And we were talking before too, sort of about the state of the specialty of facial pain and TMD disorders and treating TMD disorders, and it's evolved quite a bit. And you likened it to sort of the early days of either endo or perio. Could you talk a little bit about where the state of the specialization of pain in dentistry is today?
Sure. The organization that defines specialty training is called CODA, CODA. And the postgraduate programs that are now present in America are CODA approved. The one that I went through is CODA approved. So the whole, I have my opinion and you have your opinion, and that redheaded stepchild kind of thing around facial pain and TMJ disorders is really yesterday's news. And tomorrow's news is there is a resource available. Like every other specialty of dentistry, that resource should focus its energy on how can I educate the primary dentist to either intervene early or know when to draw the line. So if we take a specialty like perio, when perio first came out, I'm sure that every periodontist wanted every patient sent to them. But very soon they realized that's too many people. We can't see that many people. So they came up with probing. And now every general dentist probes the patient. And if there is probing depths that are unacceptable, they still oftentimes are not immediately sent to the periodontist. They're treated appropriately in the general practice until the point at which a line is drawn and they're not making progress, and therefore then they're sent on. If you take endodontics, again, an endodontist would love you to send every single patient to them. But good endodontists will say, an anterior tooth, you can do the endo. Posterior tooth with straight roots, you can do the endo. And so, it allows the generalist, who is really in charge of that patient, to draw the line wherever they want. And us as a specialty is there to give you an early out or give you a middle out or save you by getting you out.
And there's you had mentioned before to me that there's 12 facial pain educational facility. I don't know, there's like specialty programs around the country.
Yes.
So there's not enough to feed the need, and there's certainly not enough facial pain specialists across the country to see everybody. And the good news is that the people that the general dentist can't see, these are people that would be motivated to travel and find somebody. So how would you say that the general dentist should go about finding a facial pain provider to the 1% people? If somebody comes in, they have root canal in every tooth and they're complaining of pain, and they've seen 7 endodontists, right? As a general dentist, I would be like, there's the old Saturday Night Live skit, Red Flag, comes to mind.
Right.
And I'm like, oh man, if I do anything, I'm in trouble. So I would pick up the phone and probably give you a call. So how would you recommend that people find the providers?
Well, I think the future of this field in the next 5 to 10 years is going to be telemedicine. So with video conferencing, it would be very easy for a generalist that was not easily or having a specialist easily available. That would be the first place that I would say the future holds.
Well,
the second thing is I am actively pushing downstream to get generalists more familiar with these things that can be fixed if they're intervened with early.
So we have a teledentistry application in Opera DDS. So I feel like I was like setting up that, which I wasn't. What I was really getting to is that, because there's the new website, facemypain.com, too, that you have, that if you don't know who to talk to, that can link up the general dentist with providers, or even patients can go to it and find providers too.
Right,
correct?
right.
Yeah, so that's a good resource. There's lots of states where there isn't even any facial pain specialists. Is that correct?
That is correct.
So I think a big thing for the audience members, if you're a patient or work in dentistry or a dentist, that just being aware that this is a specialty that we have to send, that we're kind of obligated to find the right home for these patients, right?
Right, it is available.
So, Brian's saying that 7 root canals is going to be an indicator, but I always look at things from the patient perspective, and what from my perspective should I be looking for instead of going 7 times in to finally figure out, oh, I've got a facial pain problem, not something that a root canal is going to fix?
Anybody that sees that look on the dentist's face, like, I have no idea what is wrong with you.
Yeah.
Which is, believe it or not, really present.
Okay.
You should question, when I was doing my training, one of the things that I had to learn how to say is, I don't know.
Yeah.
Right? So you go through all this education, and when you graduate from dental school, and I was very confident in my abilities when I graduated from dental school, once I got into my postgraduate training, it took me a few months to learn how to look a person straight in the face and say, I don't know exactly what is wrong with what's going on.
Right.
I know what you don't have. I just don't know what you have. Being a dentist, I can represent to you strongly that there is a high level of pride in the service that is provided. Mm. There is a high level of ownership to and responsibility for the patient. Unlike medicine, what I do is kind of a hybrid between medicine and dentistry. And so what I've spent my career seeing is how medicine looks at a patient and how dentistry looks at a patient. And dentistry is focused on keeping a patient well. Medicine only sees you when you're sick, and then they kind of kick you out.
Which I think is a good transition into what's going to be part 2 next week on the Operatory, which is that dentists can actually incite facial pain and TMD issues. So we will be talking about that next week. So be sure to tune in. Thank you, Dr. Eli. Thank you, Dave. Happy birthday, my man.
Thank you.
Yes, and look forward to talking to you guys next week.
Thanks very much.
Thank you.
For more information about TMD, facial pain, and how to treat these patients with products like the Quick Splint, go to quicksplint.com. I also want to remind you to rate and review us wherever you're listening to this podcast. And if you have suggestions or comments, please visit theoperatory.com and drop us a line. Again, I'm Dr. Brian Laskin, host of The Operatory. Thanks for listening. I look forward to speaking with you next week.